Good day, everyone. I'm Joanne Pauline A. Casas, and I am from BSN2 Block 1. So, today I'm going to talk about a complication during pregnancy, which is called Placenta Previa. So, what is Placenta Previa? So, according to Mastrolia and Baumfeld, it is a condition of pregnancy in which the placenta is implanted abnormally in the lower part of the uterus. So it is the most common cause of painless bleeding in the third trimester of pregnancy. So here are our objectives. After this presentation, you will be able to acquire knowledge in depth regarding the definition, etiology, clinical features, diagnosis, complications, and medical management of placenta previa. Specifically, you will be able to define placenta previa and explain the etiological factors of placenta previa. Describe the types and classifications of placenta previa. Describe the clinical symptoms and diagnosis of placenta previa. Describe the risk factors and predisposing factors that may lead to placenta previa. List down the complications, effects, and dangers of placenta previa to the mother and the fetus. And describe the signs and symptoms that may manifest with the condition of placenta previa. Describe the management of placenta previa. And lastly is to list the therapeutic and nursing management that address the needs of a woman experiencing a complication of placenta previa. Before we proceed, let us first learn some terms that will help us gain better understanding as we go through our discussion. So, the first term we're going to learn is amniotic fluid. So, it is the clear liquid that surrounds a developing fetus in the mother's womb. Blastocyst is the term for the conceptus at the developmental stage that consists of about 100 cells shaped into an inner cell mass that is fated to become the embryo and an outer trophoblast that is fated to become the associated fetal membranes and placenta. Next is bradycardia. It is a slower than normal heart rate. The hearts of adults at rest usually beat between 60 and 100 times a minute. Cervical os. It is the internal opening of the cervix. Cesarean section. A surgical procedure involving incision of the walls of the abdomen and the uterus for delivery of the offspring. Contractions. It is the tightening of the uterine muscles that help move the baby from the uterus to and through the birth canal. Embryo. It is the developing human during weeks. Fetus. It is a developing human during the time from the end of the embryonic period to birth. Gestation. It is defined as the time between conception and birth. Human chorionic gonadotropin. It is the hormone that directs the corpus luteum to survive, enlarge, and continue producing progesterone and estrogen to suppress menses and secure an environment suitable for the developing embryo. Hemorrhage. A profuse discharge of blood as from a ruptured blood vessels, also called bleeding. Implantation. It is the process by which a blastocyst embeds itself in the uterine endometrium. Labor. The process of childbirth, especially the period from the start of uterine contractions to delivery. Perineum. The area between the anus and the scrotum in the male and between the anus and the vulva in female. Placenta. The organ that forms during pregnancy to nourish the developing fetus. Also regulates waste and gas exchange between the mother and fetus. Placentation. It is the formation of the placenta. It is complete by weeks 14 to 16 of pregnancy. Postpartum. It is a time after childbirth. Tachycardia. A heart rate that's too fast than the normal heart rate. Trophoblast. A fluid-filled shell of squamous cells destined to become the chorionic villi, placenta, and associated fetal membranes. Uterus. Part of the female reproductive system. It is a muscular organ where the embryo implants and grows during pregnancy. Before we proceed, let us first learn what placenta is. So, the placenta, as shown here in my diagram, is this red area here. So, the placenta is the organ that connects the fetus via the umbilical cord to the uterine wall of the mother. This is where the exchange between maternal and fetal blood takes place. The placenta provides the fetus with oxygen and nutrients and takes away waste such as carbon dioxide. Normally, it attaches at the top or at the side of the uterus. At birth, it is delivered after the baby. Placenta previa, or sometimes referred to as low-lying placenta, is a pregnancy complication in which the placenta attaches to the lower end of the uterus near or covering the cervical opening. There are 4 degrees of placenta previa. The first is low-lying placenta. In here, the placenta implants in the lower uterine segment but does not reach the cervical os. Often this type of placenta previa moves upward as the pregnancy progresses, eliminating bleeding complications later. Next is marginal placenta. The edge of the placenta is at the edge of the internal os. The mother may be able to deliver vaginally. Next is the partial previa. So in here, the placenta partially covers the cervical os, and as the pregnancy progresses and the cervix begins to efface and dilate, the bleeding occurs. Next is the total or complete previa. So the placenta here covers the entire cervical os, and usually this requires an emergency cesarean section. Placenta previa is found in approximately 4 out of every 1,000 pregnancies beyond the 20th week of gestation. So the prevalence is several-fold higher around 20 weeks of gestation than at birth because most previas identified in early pregnancy resolve before delivery. The underlying cause of placenta previa is unknown. There is, however, an association between endometrial damage and uterine scarring. But some things make you more likely to have it, and these are called risk factors. You can control most risk factors for placenta previa. So for example, you're more likely to have it if you have scars on the uterus, such as from previous surgery including cesarean deliveries, uterine fibroid removal or myomectomy, and dilation and curettage. And if you had past pregnancies or had placenta previa before, and if you are at age 35 or older, and if you're a woman who is African American or another non-white ethnic background. Risk factors that can be controlled include smoking during pregnancy and using cocaine during pregnancy. So in general examination, the general condition of the patient depends upon the amount of blood loss. Shock develops if there is an acute severe blood loss, and anemia develops if there is recurrent slight blood loss. So abdominal examinations is used to identify uterine tenderness and can be useful in differentiating other causative factors for vaginal bleeding, including uterine rupture and placental abruption. Ultrasound. It is the simplest, precise, and safe method for placental localization. A partially full bladder is necessary to identify the lower edge of the placenta. If it is less than 3 cm from the margin of the internal os, it is diagnosed as placenta previa. The posterior placenta previa is difficult to be identified due to shadowing from the presenting part of the fetus. This can be overcome by head-down tilt of the patient or displacing the presenting part manually. If difficulty is still present, the distance between the presenting part and the promontory of the sacrum is measured. If this exceeds 1.5 cm, it means the placenta lies in between. In mid-pregnancy, the placenta reaches the internal os in up to 20% of pregnancies. With increasing gestational age and the formation of the lower uterine segment, a gap develops between the placental edge and the internal os, a term called placental migration. So I'm going to talk about placental migration and as we go along through our discussion. So it is recommended to repeat scan when placenta previa is diagnosed in mid-pregnancy. Don't allow a vaginal examination to minimize placental trauma. So vaginal examination should not be done in the presence of fresh bleeding because fresh bleeding may indicate that a placenta previa is present. Performing a vaginal examination in this instance might tear the placenta and cause hemorrhage, resulting in danger to both the mother and fetus. Make certain a primary care provider knows about the fresh bleeding before attempting a vaginal examination. The majority of women with placenta previa in developed countries will deliver healthy babies, and the maternal mortality or death rate is less than 1%. In developing countries, however, where medical resources may be lacking, the risk for mother and fetus may be higher. Placenta previa can be associated with other abnormalities of the placenta or of the umbilical cord. Some studies have shown a reduction in fetal growth associated with placenta previa, and the presence of the placenta in the lower part of the uterus makes breech or abnormal presentation of the fetus more likely. The bleeding of placenta previa can increase the risk for preterm premature rupture of the membranes, leading to premature labor. Placenta accreta is a serious complication that occurs in 5% to 10% of women with placenta previa. Placenta accreta results when the placental tissue grows too deeply into the womb, attaching to the muscle layer, resulting in difficulty separating the placenta from the wall of the uterus at delivery. This complication can cause life-threatening bleeding and commonly requires hysterectomy at the time of cesarean delivery. Risk of placenta accreta is 3%, 11%, 40%, 61%, and 67% for the first, second, third, fourth, and fifth or more cesarean deliveries, respectively. Postpartum hemorrhage is blood loss greater than or equal to 1000 ml, accompanied by signs or symptoms of hypovolemia occurring within 24 hours after delivery, regardless of the route of delivery. So vaginal bleeding secondary to placenta previa can lead to postpartum hemorrhage, requiring a blood transfusion, hysterectomy, maternal intensive care admission, septicemia, and maternal death. This condition may necessitate blood transfusion, uterotonics, uterine artery embolization, iliac artery ligation, balloon tamponade, and hysterectomy. Placenta previa that is not diagnosed early enough or managed improperly can lead to morbidity and mortality for both the mother and fetus. Placenta previa is also associated with intrauterine growth restriction or retardation, placental insufficiency, fetal distress, preterm birth, low birth weight, birth defects, low APGAR scores, longer duration of hospitalization, higher blood transfusion rates, and shock. So according to Gaiman, bleeding is the primary symptom of placenta previa and occurs in the majority of 70% to 80% of women with this condition. Bleeding is bright red in color and is associated with the stretching and thinning of the lower uterine segment that occurs during the third trimester. I will explain it later as we go along with the discussion. Usually, the bleeding is painless, but it can be associated with uterine contractions and abdominal pain. The uterus is not able to adequately contract and stop blood flow from open vessels. Bleeding may range in severity from light to severe. So here are possible nursing diagnoses. Fear related to outcome of pregnancy after episode of placenta previa bleeding. Fear related to threat to maternal and fetal survival secondary to excessive blood loss. Deficient fluid volume related to active blood loss secondary to disrupted placental implantation. Decreased cardiac output related to altered contractility. Ineffective tissue perfusion related to decreased hemoglobin concentration in blood and hypovolemia. Risk for impaired fetal gas exchange related to disruption of placental implantation. Active blood loss or hemorrhage related to disrupted placental implantation. Activity intolerance related to enforced bed rest during pregnancy secondary to potential for hemorrhage. Altered diversional activity related to inability to engage in usual activities secondary to enforced bed rest and inactivity during pregnancy. There normally exists an apparent placental migration, with one edge of the placenta growing while the opposite edge atrophies. The placenta at the 20th week of gestation is well developed and matured and needed more blood supply, so it migrates to a more vascularized part of the uterus, and it is believed that this migration is impaired in women with surgically scarred uteri, which is why they are at a greater risk for placenta previa. So early on in the course of pregnancy, if a woman is diagnosed with placenta previa, it tends to not be that big of a deal. And the reason for that is because as the pregnancy progresses, the baby grows. And as the baby grows, the uterus gets larger and it stretches out. And with the stretching out of this uterus, the placenta gets dragged along to a higher position. So if a woman is found to have placenta previa early on the course of her pregnancy, as the uterus grows, the condition tends to self-resolve, and the placenta tends to find itself in a normal position by the end of pregnancy. So much so that it's pretty rare to still have the condition by the time the baby is ready to be delivered. If, however, she's found to have placenta previa later on in the course of her pregnancy, or if she was found to have it earlier and it still persists by the time that she's ready to be due, it tends to be a very big deal. And the reason for that is that in this location, the placenta is really prone to bleeding, and I want to show you why that is. So if I expand this or zoom into this part of the uterus, so this is the uterus, or rather the wall of the uterus, and the uterus is a muscle, right? So it's a muscular organ. So in a non-pregnant woman, there are all these blood vessels or arteries, and they're called uterine arteries that come down to the uterus and they supply it with oxygenated blood. Because again, the uterus is a muscle, so it needs a lot of oxygen. So what happens in pregnancy is that these uterine arteries become really juicy and plump, and they actually cross the wall of the uterus, and they squirt out all this blood into the placenta. So the placenta is kind of like a pool of blood, and the baby also sends down blood vessels into the placenta so that it can get access to all the oxygen and all the nutrients from the pool of blood that is the placenta. So when the baby is pretty close to being delivered, or when babies make their exit from the uterus, they do so head first, and their heads tend to be pretty big, and you can see that this thick and plump part of the uterus, the cervix, is kind of standing in the way of the baby's head. So what happens toward the end of the pregnancy is that the wall of the uterus over here at the cervix tends to widen the passage for the baby. Now, normally this is a good thing, but if the placenta is sitting right here like it does with placenta previa, it can be a pretty dangerous thing. So when the wall of the uterus thins out, the attachment here, the attachment between the uterus and the placenta is actually strained. So it starts to become weakened and the placenta starts to detach. So, and as you can imagine, these uterine arteries, which are actually in the wall of the uterus, are being tugged on this direction. And as the wall thins out, but since they're also attached to the placenta, they're also being tugged on in this opposite direction. So pretty easily, the tension on these arteries can cause them to rupture, and blood leaks through the vagina. So that's actually how placenta previa tends to present with vaginal bleeding late in the course of pregnancy. So that's called antepartum bleeding. So at this juncture, I'm going to discuss the schematic diagram. So as you can see here in this box, these are the risk factors. So age is a risk factor. Age is associated with varying incidence of placenta previa. The risk of placenta previa is increased with increasing maternal age. Placenta previa in turn increases the risk of complications like obstetrical hemorrhage and the need for cesarean hysterectomy. Placenta previa is associated with male births. The reason for this is not known, but it could be linked to maternal hormones or prematurity. Premature rupture of membranes occurs more commonly in pregnant women with male births, and placenta previa is also more common in premature pregnancies. Mothers with placenta previa have a tenfold risk of reoccurrence in a subsequent pregnancy. This is thought to be linked to defective decidual vascularization. The contributing factors for placenta previa is a previous delivery by cesarean section. The risk increases with the number of cesarean sections performed. The incidence is 2% after 1 previous cesarean section, 4.1% after 2, and 22% after 3. Similarly, dilation and curettage, evacuation of uterus, and myomectomy are associated with placenta previa and is more common in older and multiparous women. The reason is not clear, but it may be associated with the aging of vasculature of the uterus. This causes placental hypertrophy and enlargement, which increases the likelihood of the placenta encroaching on lower segment. Multiple pregnancies are also associated with placenta previa. This is because the large placenta usually encroaches on lower segment of the uterus. Birth spacing is also associated with a risk of placenta previa. In a study carried out among Norwegian women, it was found that the birth spacing of more than 4 years was associated with placenta previa. This could be due to scarring or poor vasculature of the uterus, which is associated with increasing age. Moreover, abnormal placentation and smoking have been attributed to abruptoplacenta and placenta previa. Smoking seems to increase the risk of previa via a hypoxemia-related mechanism. Nicotine has a vasoconstricting effect on utero-placental perfusion in smoking mothers. Placental studies have demonstrated decreased vascularization and pronounced changes in the broad basement membrane of mothers who smoked cigarettes. The underlying cause of placenta previa is unknown. There is, however, an association between the endometrial damage and uterine scarring. The implantation of a zygote or a fertilized egg requires an environment rich in oxygen and collagen. The outer layer of the dividing zygote, or blastocyst, is made up of tropoblast cells which develops into the placenta and fetal membrane. The tropoblast adheres to the decidua basalis of the endometrium, forming a normal pregnancy. Prior uterine scars provide an environment that is rich in oxygen and collagen. The tropoblast can adhere to the uterine scar, leading to the placenta covering the cervical os or the placenta invading the walls of the myometrium. There normally exists an apparent placental migration, with one edge of the placenta growing while the opposite edge atrophies. This is what I have discussed in the previous slide. So, it has been noted that the placenta initially will occupy from 1/2 to 1/3 of the uterine wall. By term, however, no more than 1/4 to 1/6 of the uterine surface is covered. This change in ratio permits a degree of apparent placental movement. In placenta previa, it is postulated that there is an impairment of this normal placental progression away from the cervical os, and it's believed that this migration is impaired in women with surgically scarred uteri, which is why they are at a greater risk of placenta previa. So this part here is what I have mentioned in a previous slide. So it occurs in 4 degrees: the low-lying, the marginal, the partial, and the complete or total placenta previa. So towards the end of the pregnancy, the wall of the uterus at the cervix thins out to widen the passage for the baby, and normally this was a good thing. But in placenta previa, when the wall of the uterus thins out, the attachment between the uterus and the placenta is strained, and it starts to become weakened and the placenta starts to detach. So the uterine arteries, which are in the wall of the uterus, are being tugged on in one direction, and as the wall thins out, since they are also attached to the placenta, they are also being tugged on in the opposite direction. So the tension of these arteries can cause them to rupture and the blood leaks through the vagina. So bleeding is the primary symptom of placenta previa, and it occurs in the majority of 70% to 80% of women with this condition. So, vaginal bleeding after the 20th week of gestation is a characteristic of placenta previa. The placenta in this stage is well developed or mature and needed more blood supply, so it migrates to a more vascular part of the uterus. So, bleeding that is bright red in color is associated with stretching and thinning of the lower uterine segment that occurs during the 3rd trimester. Usually, the bleeding is painless, but it can be associated with uterine contractions and abdominal pain. The uterus is not able to adequately contract and stop blood flow from the open vessels. The most common cause of fetal distress is when the baby doesn't receive enough oxygen because of problems with the placenta, including placental abruption or placental insufficiency. So, placental insufficiency occurs when the placenta does not develop properly or is damaged. So, this blood flow disorder is marked by a reduction in the mother's blood supply. The complication can also occur when the mother's blood supply doesn't adequately increase by mid-pregnancy. When the placenta malfunctions, it's unable to supply adequate oxygen and nutrients to the baby from the mother's bloodstream. Without this vital support, the baby cannot grow and thrive. This can lead to low birth weight, premature birth, and birth defects. Low birth weight is defined as a birth weight of an infant less than 2,500 grams at full term. It can result from intrauterine growth restriction and or preterm birth. So intrauterine growth restriction is often a comorbidity of preterm birth, and it's linked with induction of assisted and non-assisted premature delivery. Moreover, excessive maternal hemorrhage can cause a severe drop in blood pressure, and it may lead to shock and death if not treated. For a first episode of vaginal bleeding before 36 weeks, management consists of hospitalization, modified activity, which involves refraining from any activity that increases intra-abdominal pressure for a long period of time, and avoidance of sexual intercourse, which can cause bleeding by initiating contractions or causing direct trauma. If bleeding stops, ambulation and usually hospital discharge are allowed. Typically, for a second bleeding episode, patients are readmitted and may be kept for observation until delivery. Some experts recommend giving corticosteroids to accelerate fetal lung maturity when early delivery may become necessary and gestational age is less than 34 weeks. Corticosteroids may be used if bleeding occurs after 34 weeks and before 36 weeks or late preterm period in patients who have not required corticosteroids before 34 weeks. Timing of delivery depends on the maternal and or fetal condition. If the patient is stable, delivery can be done at 36 weeks to 37 weeks. Documentation of lung maturity is no longer necessary. Delivery is indicated for any of the following: heavy or uncontrolled bleeding, non-reasoning results of fetal heart monitoring, maternal hemodynamic instability. Delivery is cesarean for placenta previa. However, vaginal delivery may be possible for a woman with a low-lying placenta if the placental edge is within 1.5 to 2.0 cm of the cervical os, and the clinician is comfortable with this method. Hemorrhagic shock is treated. Prophylactic Rho-D immune globulin should be given if the mother has Rh-negative blood. Here is a list of nursing management. Inspect the perineum for bleeding and estimate the present rate of blood loss. Weighing perineal pads before and after use and calculating the difference by subtraction is a good method to determine vaginal blood loss. Obtain baseline vital signs to determine whether symptoms of hypovolemic shock are present. Continue to assess blood pressure every 5 to 15 minutes or continuously with an electronic cuff. Never attempt a pelvic or rectal examination with painless bleeding late in pregnancy because any agitation of the cervix when there is a placenta previa might tear the placenta further and initiate massive hemorrhage, possibly fatal to both mother and child. Attach external monitoring equipment to record fetal heart sounds and uterine contractions. An internal monitor for either fetal or uterine assessment is contraindicated. Hemoglobin, hematocrit, prothrombin time, partial thromboplastin time, fibrinogen, platelet count, type and cross-match, and antibody screen will be assessed to establish baselines, detect a possible clotting disorder, and ready blood for replacement if necessary. Monitor urine output frequently, as often as every hour, as an indicator if her blood volume is remaining adequate to perfuse her kidneys. Administer intravenous fluid as prescribed, preferably with a large gauge catheter to allow for blood replacement through the same line. A vaginal birth is always safest for an infant. It is essential, therefore, to determine the placenta's location as accurately as possible in the hope that its position will make vaginal birth feasible. If the previa is under 30% by abdominal or intravaginal ultrasound, it may be possible for the fetus to be born past it. If over 30% and the fetus is mature, the safest birth method for both the mother and baby is often a cesarean birth. If only a minimum previa is detected by sonogram, the primary healthcare provider may attempt a careful speculum examination of the vagina and cervix to establish the degree of fetal engagement and rule out another cause for bleeding such as ruptured varices or cervical trauma. This should be done in an operating room or a fully equipped birthing room so that if hemorrhage does occur with cervical manipulation, an immediate cesarean birth can be carried out to remove the child and bleeding placenta and contract the uterus. Have oxygen equipment available in case the fetal heart sounds indicate fetal distress, such as bradycardia or tachycardia, late deceleration, or variable decelerations during the exam. That ends my presentation. Thanks for listening.